You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for professionals. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and an LLS volunteer. And I want to thank all of you for joining us on this episode. Today, we're going to be talking about myelodysplasia, including diagnostics, treatment strategies, and decision-making, patient-centered care, and side effect management. We're delighted to be joined by Dr. Mikkel Sekaris, who is the chief in the Division of Hematology and professor of medicine at the University of Miami's Sylvester Comprehensive Cancer Center. Mikkel is also the author of When Blood Breaks Down, which is a wonderful book that I want to recommend about the science of treating patients with leukemia, but also the more personal side of it as well. Mikkel, thanks for being with us.
Ken, how delightful it is to be here. Thank you for having me.
So I was a fellow many, many years ago when myelodysplasia was really described by the French American British group morphologically. And I'd love your broad view, 60,000 foot view first about what we know about myelodysplasia now compared to what was known then, and where have the big breakthroughs been?
Yeah, well, as it happens, Ken, I was a fellow many, many years ago also. And myelodysplastic syndrome is really different now than how it was back then. You know, back then, people were hesitant to call it a cancer. And I even had interactions with great patient advocacy groups like the Leukemia and Lymphoma Society or the Aplastic Anemia and MDS Foundation about whether to use the word cancer in materials that went to patients because it was so controversial. In the end, we decided to use the word because we wanted to emphasize to patients just how serious a diagnosis this can be. And also, what I was experiencing in my own clinic is patients were being told by their doctors that they had a, quote, blood disorder. We even published a study about this in The Oncologist about what was the first word used to describe myelodysplastic syndrome to patients who had the diagnosis. And really, for about 90% of them, it was either blood disorder or a bone marrow disorder. But the word cancer or something akin to leukemia was only used about 7% of the time. So, boy, were my patients surprised when they came into my clinic and I started to talk to them about how we were going to use a drug like azacitidine, which is a chemotherapy, to treat their blood disorder. So the first step in reclassifying myelodysplastic syndromes was really when the World Health Organization undertook this, both in 2001 and then later, of course, in 2008, 2016, and most recently in 2022, to emphasize the fact that now we actually refer to these diagnoses as neoplasms. We still use the MDS abbreviation, but now we refer to them as myelodysplastic syndromes or myelodysplastic neoplasms.
So I want to ask you about that a little bit more because it is different, at least I think, between calling something a neoplasm and calling it a cancer.
Mm-hmm.
There is a difference. I find when I'm seeing someone with myelodysplasia, I'm still leaning toward the gentler side and saying neoplasms. But what do you do as you're talking with patients?
Yeah, I think that's a natural human tendency to want to soft shoe the diagnosis a little bit when you're looking at someone who is in his or her late 70s, 80s. Often they'll have one of their kids with them as well to accompany them to the appointment. And no one has been brave enough to use the phrase neoplasm or cancer. So the way I describe it to patients is you have myelodysplastic syndromes. I think that's still the most common way it's described. I go over what it means, how MDS arises. I talk about the fact in plain language that it's a clonal disorder. And then I say, you or your kids may have gone online and seen a scary word associated with that, and that scary word is cancer. Let me put it in context. And if somebody has a lower risk myelodysplastic syndromes, I'll say this is more of a lower C cancer. And I'm sure you have friends or family members who've had cancer and they've lived with it for years. And that's what we're talking about here. But I do think for higher risk myelodysplastic syndromes, where the median survival is less than a year and a half, we do have to be brave and put on the big boy or big girl pants and use the word cancer with our patients and emphasize to them that it's a serious diagnosis that needs serious treatment.
Yeah. So, in a sense, the description that comes after the words is obviously just as important. And framing it as, again, a chronic illness or more of a acute and life-threatening illness that it can be.
Well, that's exactly right. I mean, if we soft shoe it and say it's a blood disorder and then say, and now I'm going to treat you with 7 days of azacitidine every 28 days or 5 days of decitabine for as long as this works for potentially the next 1, 2, 3, 4 years, gee whiz, that's not going to make a lot of sense if you don't use a word to describe the seriousness of it also.
Let me ask you, in that framework of high risk and low risk, how would you describe high risk? How would you describe low risk using sort of the classifications that we're using now in 2025? From a morphologic point of view, a molecular point of view, a genomic point of view, what are the main things that make these two what they are?
Sure, I think that's a great question, and it's changed over time. To be honest, I think within the MDS world, we're guilty of making this really ridiculously complicated. You almost wonder if it's job security. We're trying to confuse people so they don't understand it, so we can still be specialists in it. But it really boils down to some very basic facts. So myelodysplastic syndrome are characterized by cytopenias. About 80% of people with MDS have an anemia, but people can also have neutropenia or thrombocytopenia. The more cytopenias you have, the worse the MDS. That's fact number one. Fact number two is that it can be very similar to acute myeloid leukemia, particularly biologically like acute myeloid leukemia in older adults. So blasts are important. Fewer than 5% blasts, we generally consider to be lower risk. The more recent iterations of prognostic scoring systems make a dividing line at 2% blasts. So 2% or fewer blasts is really lower risk. Once you start to get to 3 or 4 or 5% blasts, you're starting to creep up there. And then more than 5% blasts, you start to get to a condition where you have a true block in differentiation, just like you have with acute myeloid leukemia. So blasts matter. More recently, there have been attempts to start to ask the question about where we make the dividing line between myelodysplastic syndromes and acute myeloid leukemia. Classically, that has been at 20% blasts. So once you have 20% blasts, we say you have acute myeloid leukemia. If you have fewer than 20% blasts, you have myelodysplastic syndromes. But really, that 10 to 20% range, there's not that much difference between a higher risk myelodysplastic syndrome and an acute myeloid leukemia. So we're still deciding where that bar is. For now, I would say the standard is to still say 20% blast is acute myeloid leukemia. Fewer than that is still higher risk myelodysplastic syndromes. So far, I've talked about cytopenias. I've talked about blasts. The third arm to this are the genetics. So we've gotten pretty good at figuring out the genetics of myelodysplastic syndromes. We have some genetic abnormalities, chromosomal abnormalities that we associate with a good risk myelodysplastic syndromes, and those can be abnormalities in -Y, deletion 5q, deletion 20q. And we have some abnormalities that we associate with poor risk in myelodysplastic syndromes. Those occur when we get the karyotypic report back and we have a paragraph long of mutations, right? Someone who
Yeah.
has a lot of mutations like that has a very poor risk of myelodysplastic syndromes. And of course, we associate abnormalities of chromosome 7 or chromosome 3 with poor risk. So everything else kind of falls somewhere in the middle. And I'm grossly oversimplifying that, but that's because we've grossly overcomplicated it in how we think about myelodysplastic syndromes. So to summarize, cytopenias, blasts, and karyotypic abnormalities. Those are the things that go into the revised International Prognostic Scoring System. That's what we use as our quote-unquote staging system for myelodysplastic syndromes. Now, MDS has become even more complicated than that, particularly over the past decade, as we've been focusing on molecular abnormalities. And there are some classic molecular abnormalities associated with myelodysplastic syndromes. So it is absolutely requisite that patients who are undergoing a bone marrow biopsy for potential diagnosis of myelodysplastic syndromes also receive next generation sequencing panels for myeloid mutations. And it's now gotten so complicated that I can't do this on the back of an envelope anymore to calculate out a risk score. We've got to go online. If you do a search on IPSS-M, M for molecular, you'll have a very easy to use calculator where you plug in information about a patient's blood counts, a patient's age, karyotypic abnormalities, and molecular abnormalities, and it will now kick out a score that tells us whether a patient is lower risk or higher risk. Higher risk is a positive score, lower risk is a negative score with the IPSSM.
So let's take it to the next step. There is a group, and I can think of patients in my practice who would be defined as low risk. They have, let's say, some morphologic changes. They don't have, I'm thinking of one woman in particular, no cytogenetic abnormalities, but a few things on fish. We talk about a watch and wait approach or supportive care.
Sure.
What's the state of therapy, the state of the art now for someone like that?
Let's start with higher risk MDS. If a patient has a diagnosis of higher risk MDS, I believe we need to start treating that patient immediately. And the reason is, as I mentioned before, if the median survival is less than a year and a half, we have to start therapy to try to prevent that MDS from going into acute myeloid leukemia because the rate of transformation is so high with higher risk MDS, but also to prolong someone's overall survival. The only level 1 evidence we have in higher risk MDS for treatment is with the drug azacitidine, where there is a randomized trial, the AZA-001 study, in which patients with higher risk MDS received azacitidine or conventional care regimens. On that study, patients who received azacitidine actually lived longer, significantly longer than when they received conventional care regimens. So that's why it's so important, first of all, to start by figuring out, does someone have lower risk or higher risk MDS, to know how urgent it is to start therapy. So with higher risk MDS, our goals of therapy are to try to prolong overall survival, prevent transformation to acute myeloid leukemia, and provide somebody with a better quality of life, maybe by improving their blood counts. With lower risk MDS, no prospective randomized trial has ever demonstrated that intervening with a drug is going to allow someone to live longer. So if I'm not allowing somebody to live longer with a drug with lower risk MDS, the only thing I'm adding to that person's ability to feel better is to minimize their transfusions or maximize their quality of life, right?
Yes.
So if somebody with lower risk MDS has a really good quality of life, let's say they had an abnormal blood count, their primary care physician recommended they go to a hematologist, the hematologist did a bone marrow biopsy, and lo and behold, they have lower risk MDS, but never would have known it otherwise. The only thing I'm going to add to that person if I try to treat them are side effects to a drug.
Yeah, exactly.
Right? So those are the folks we follow with active surveillance. And it may be that I see somebody every 6 months. It may be that I see them every month, depending on where on the spectrum of lower risk MDS they fall.
So really getting down to some nitty gritty, erythropoietin, luspatercept. Again, what are some ways to decrease transfusion burden, for example?
So if somebody doesn't yet need blood transfusions, if their platelets are pretty good. Sometimes I make the joke they're good enough for government work, right? They get the job done. They may not be perfect, but they get the job done.
Yeah.
They haven't had recurrent infections, then there's nothing we have to do.
Okay.
Once someone's hemoglobin starts to drop, particularly as it gets closer to 8, hemoglobin of 8 is generally our transfusion threshold for lower risk myelodysplastic syndromes. A lot of people will use a hemoglobin of 7 because of the studies that have been conducted in the hospital where there's no difference in outcome if people are transfused at a hemoglobin of 7 or 9. But those studies were conducted in patients who were in intensive care units. It's not the same population as our older adults who are outpatients. So
good point.
Transfusion threshold of 8 is generally what we use in the MDS community. So once a person starts to get down towards 8, 7.9, 7.8, they're going to start to feel it, particularly since these tend to be older adults.
Mm-hmm.
And that's when we start to think about initiating therapy. We can start off with a blood transfusion. If a person needs a blood transfusion every 2 or 3 months, and I have a couple patients like this, that's probably not too bad a quality of life. But once my patients start to need a blood transfusion more frequently than once per month, they start to complain about it a lot. It becomes a burden to them to have to come to the infusion center to get that blood. And that's when we start to think about initiating therapy. An easy first step in initiating therapy are erythropoiesis stimulating agents.
Yep.
Now, it doesn't take an MDS nerd like me to know that if a patient has a sky-high EPO level already in their serum, an EPO level of 700, 1,000, and they're already starting to require blood transfusions, giving them exogenous EPO probably isn't going to work. Their body's already cranking out a lot of EPO.
Yeah.
If, on the other hand, you have a patient who has an EPO level that's less than 100, so higher than upper limit of normal for labs, which is usually around 25, but lower than 100, the likelihood that that person is going to respond to EPO is actually pretty good. You're probably getting into the range of about 50 to 75% chance that it's going to work. So giving EPO as a first step is a great idea. Now, with MDS, we don't give the same doses that we would to a patient who has renal failure. A patient with renal failure may get 10 or 20,000 units of recombinant humanized erythropoietin every week. For somebody with MDS, that's going to be closer to 60,000 units.
Per week?
Per week for recombinant humanized erythropoietin. If we're using darbepoetin, the U.S. study actually used 500 micrograms every 3 weeks, and then if patients didn't respond after about 12 weeks, you give it every 2 weeks.
Just to comment that, I mean, it's a very well-made point that the renal dosing is not the right dosing for MDS.
Yeah, I mean, I'm glad you're emphasizing that also, Ken.
Yeah.
So one of the referrals where I look like a rock star, but I'm not such a rock star, is patients not responding to EPO from their doctor who's giving 10 or 20,000 units a week, right? I come up with the magic of giving 60,000 a week, and all of a sudden their hemoglobin
He's so
improves.
smart.
So I think EPO is a great starting point. You mentioned luspatercept. There have been a couple of randomized trials with luspatercept, and luspatercept has a couple of indications on its label. One of those indications is for upfront therapy of patients who have transfusion-dependent anemia with lower risk myelodysplastic syndromes. Now, in this study, patients were enrolled if they had ring sideroblasts or an SF3B1 mutation. SF3B1 mutations are almost a sine qua non for ring sideroblasts, or if they didn't. And on this study, upfront therapy with luspatercept led to a transfusion independence response rate lasting 12 weeks or longer of about 60%, compared to about 31% for patients who got erythropoiesis stimulating agents.
Mm-hmm.
And the duration of that response was actually over 2 years. It was pretty impressive.
It is.
But the caveat to this trial is that almost all of the improvement in response to luspatercept over erythropoiesis stimulating agents was driven by patients who had ring sideroblasts and or SF3B1 mutations. So they were true rock stars. They had this incredible different rate of transfusion independence with luspatercept versus erythropoiesis stimulating agents. But when you looked at those patients who didn't have ring sideroblasts or didn't have an SF3B1 mutation, the response rates to ESAs or to luspatercept were about the same. So my approach to these patients, if they don't have ring sideroblasts and don't have an SF3B1 mutation, is it's dealer's choice. You can start with an erythropoiesis stimulating agent, and then when that stops working, or if it doesn't work, you can then consider going to luspatercept in second line. For those patients who do have ring sideroblasts or an SF3B1 mutation, you can certainly start with luspatercept and then consider erythropoiesis stimulating agents as a second line, although we really don't have a lot of data about the effectiveness of ESAs following luspatercept.
So we used to look at ring refractory anemia with ring sideroblasts, that group, even as, some were pyridoxine responsive. The reason I bring it up is, what is there in particular about that biology that makes it sort of its own subset? Anything about the molecular biology?
Yeah, Ken, that's a great question, and one that I don't think we really know the answer to. I wonder if it has something to do with iron transport mechanisms, because it is different in patients who have ring sideroblasts. That's why they have the rings compared to those who don't. But we really don't know. And you could certainly make the case and say, as you reflect over the past 20 years of treatment of MDS, you could say, well, wait a second, those folks with ring sideroblasts seem to do better with every therapy. Is there really something special about luspatercept versus not? And the answer is, I don't know. What I do know is there's a randomized trial that shows that those folks with ring sideroblasts sure do seem to respond better to luspatercept than folks who don't have ring sideroblasts.
Let me ask you about, because we've talked some about low risk and what I would call supportive care. You've made a very good point about, I'll use my own words, which is if it ain't broke, don't fix it. All
Right.
right. Or at least, do no harm. There's an intermediate group who are probably not on the very verge of developing acute leukemia, but have some blasts and they have cytopenias. Let me ask you about one group in particular who have neutropenia. There, let's say some anemia or thrombocytopenia, but where neutropenia is the biggest issue. How do you manage them? Do you use chronic antibiotics? Is a growth factor, in a sense, a no-no? That's how I've learned it. But what are your views?
Yeah, they're a tricky population. There are some patients with MDS, about 6% have an isolated neutropenia, so it's relatively rare. Often we'll see neutropenia in combination with other cytopenias, as you say, as patients start to slouch towards intermediate and higher risk MDS. For patients who have an isolated neutropenia or where the neutropenia is the predominating cytopenia, the very first thing I do, and we've heard this phrase in medicine before when we say to each other, don't just do something, stand there, right? The opposite of what you hear in the
Sure.
movies where they say, don't just stand there, do something. In medicine, the hardest thing in the world is to not do something,
Yes, yes.
is I watch those patients over time to try to figure out if they have a functional neutropenia. So the blood counts may be low, but we've all seen these folks who have neutropenia where they get an infection. All of a sudden, those neutrophils rise and they
Yeah,
have a good
yeah.
response to
Yep,
an
yep,
insult, right? So if I have a patient who's neutropenic, but they're not getting infections and I follow them for 6 months, a year and a half, then once again, maybe the best thing to do is nothing, is just watch them over time.
sure.
If I have patients who get recurrent infections, I will start to introduce prophylactic antibiotics. I do not use growth factors to stimulate the neutrophils, though. I think it's a Pyrrhic victory. I think we're convincing ourselves that we're making
Yeah,
something better by
yeah,
raising the numbers. I don't know
yep.
that we're improving a functional immune response.
Got it. Yeah, thank you.
So then the question is, what do you do with these folks? What happens when they do start to get infections? And that's when we start to think about hypomethylating agents. There's a dirty little secret in drug development in MDS, and that is that if 80% of patients have some degree of anemia, drug development is going to focus on anemia. That's the market share. So you don't have drugs that are focusing on isolated neutropenia or isolated thrombocytopenia.
Yeah,
So what we wind up doing for these folks is to introduce hypomethylating agents. So the same drugs that we use for higher risk MDS, although there's a study in which we participated for the MDS Clinical Research Consortium where we showed that giving less is more. So instead of giving 5 days of decitabine or 7 days of azacitidine, maybe 3 or 5 days of azacitidine or 3 days of decitabine is enough.
got it. Very interesting and appealing because, again, we're treating a group with cytopenias with drugs that are somewhat myelosuppressive.
Right, exactly, particularly with lower risk MDS. With higher risk MDS, again, we're slouching towards a much more serious disease. And biologically, we're looking at something that is almost acute myeloid leukemia. Even if you look at the molecular characteristics of these diagnoses, higher risk MDS is very similar to acute myeloid leukemia. And maybe someone with higher risk MDS has on average 3 molecular mutations. Someone with secondary acute myeloid leukemia has 4. So we literally see in the biology how higher risk MDS becomes secondary acute myeloid leukemia.
Let me ask you about evolution from MDS into leukemia. What do we know as a field about how that occurs? Are the repair mechanisms gradually deteriorating? What have we learned?
I've done some translational research from clinical translational research looking at the genetics of myeloid malignancies. So I really think about it from a genetics perspective. And then I also have a background in epidemiology, so I throw in some statistics into it, right? So stochastically, MDS evolves over years or decades. How do we know that? We've got 2 levels of evidence to say that. The first is an epidemiologic study. There was a publication in JCO from the Atomic Bomb Research Institute where they found they have incredible detailed information about where a group of people were standing in relation to where the atomic bomb was dropped on Hiroshima or Nagasaki. And based on that, they've actually calculated the dosimetry of their radiation exposure. And what they found is that these folks who were exposed to the atomic bomb, when compared to people in Japan who weren't exposed to the atomic bomb, have 17 times the likelihood of developing MDS in the 1970s, 80s, and 90s. Remember, the atomic bomb was dropped in 1945.
Yeah, so very long. So you're saying that process has been going on for 40
For
years.
decades, right?
Yeah,
For
yeah,
decades.
yeah.
So that's epidemiologic evidence for my claim. The biologic evidence for it are the work that we and others have done, particularly people like Lucy Godley at University of Chicago, looking at germline mutations that lead to myeloid malignancies. So I myself had a patient who invited his identical twin in to meet me as well, both of whom had MDS in their 60s. And we uncovered that they had a germline mutation in the DDX41 helicase abnormality. So those folks were born with something that didn't rear its ugly head morphologically until they were in their mid 60s. Again, decades of evolution. So now let's turn this to your question about the evolution of MDS to acute myeloid leukemia. You get one mutation probably at some point when we're younger, and we see this in folks with CHIP, right? Clonal hematopoiesis of
Yep,
indeterminate
yep.
potential, where we see that rise in people who have these mutations we associate with myeloid malignancies. It starts when we're younger in our 40s and 50s, but really starts to take off in our 60s and 70s, right? That's mutation number one. Add to it something in our environment. Maybe it's somebody who smokes. Maybe it's somebody who got radioactive iodine for thyroid cancer, or radiation for prostate cancer, or chemotherapy or radiation therapy for breast cancer or lymphoma. That adds mutation number two, maybe mutation number three. Then you have cells that have already shown a proclivity to develop mutations that are inherently unstable and more likely to develop that fourth mutation. And that's when you're getting from MDS to acute myeloid leukemia.
Yeah. Let me ask you some questions about the host, because I have found it interesting. Well, obviously, that there's patients who are treated, let's say, for leukemia and go into remission and do well. There's people that don't. And this is obviously moving more into the leukemia side. It could be high risk MDS as well. Is there any known difference in terms of immune surveillance, since this is a time when, obviously, as clinicians, we're very tuned into immunotherapy?
Sure. Another great question. So there are data showing that patients who have autoimmune conditions are more likely to develop myelodysplastic syndrome, right? So it is definitely an immune dysregulation problem. And we have data from patients who have aplastic anemia, which is a T cell mediated bone marrow destruction process, who obviously have more of a proclivity for developing myelodysplastic syndromes. And you can see them develop mutations over time. So there is an immune surveillance problem, I think, that is more predominating in a subset of patients with myelodysplastic syndromes. That also describes why drugs like antithymocyte globulin work in about a third of patients with lower risk MDS. So fascinating, right?
It is.
But let's get to your question about immunotherapy and CAR T cell therapy. Why the heck hasn't that worked then in patients with
Yes,
myelodysplastic syndrome?
why?
It's been a real dud. It really has been. And I think that's because, particularly as we move towards higher risk MDS, I don't think it's the immune surveillance problems that are predominating. I think then you're getting much more into a clonal process where you need a damaged hematopoietic cell precursor to be either corrected or removed. And more blunt instruments like chemotherapy, hypomethylating agents are going to be more effective.
Got it. Any new insights since demethylating agents became available, at least the way I've described it to patients or to internal medicine colleagues, is that we're unsilencing certain genes that are favorable. Is that the case, or is it more complex or different?
When I talk to patients about this, because they'll ask me, how does this drug work? I think there are three ways that it works. One is exactly what you're talking about, where we talk about these CPG islands on tumor suppressor genes, right? That methyl groups are added to tumor suppressor genes. They turn the tumor suppressor genes off. Therefore, the genes don't suppress the tumor. Hypomethylating agents, or DNA methyltransferase inhibitors, are protecting those tumor suppressor genes from methylation, allowing them to be transcribed and thus allowing suppression of the tumor. That's mechanism number one. Mechanism number two is as differentiation agents. So we have these cells in MDS and in acute myeloid leukemia that are stuck at immature stage of development. And this is helping march them along so that they eventually become like mature neutrophils. Mechanism number 3 is directly cytotoxic. So when we see people who are treated with hypomethylating agents, we sometimes see a little bit of all of this occur. Sometimes we don't see a lot of difference in cytopenia. Sometimes we see patients become profoundly cytopenic to these drugs, and we see that cytopenia occur in different weeks of a 4-week cycle. And so I think that's where you're seeing the kind of which of those mechanisms of attack are actually predominating.
Wow, and very interesting and subtle. I mean, in many ways, to accept someone who's seeing this all the time in a large number of patients. So thank you. Let me ask you about a patient, and I'm interested in your thinking process. So I'm seeing a woman now who's 78 years old, in fairly good health, not a lot of comorbidities, but not robustly in good health in terms of just general lifestyle and abilities. She has high risk MDS. She's got about 15% blasts. She's got one of those paragraphs of cytogenetics, as you described it, and she's really very high risk. I've been treating her with azacitidine, and we're maybe 4 months into it. I can't say there's been any big change, but how do you think through the care of a patient like that? What is the role for transplant?
So, what we've learned from a bunch of randomized trials that we've conducted looking at combination therapies is how critically important it is. I can't emphasize this enough how critically important it is to maintain the dose and the schedule of the hypomethylating agent during the first 4 to 6 cycles of therapy. And we learned from a variety of trials, the North American intergroup trial, where azacitidine was compared to azacitidine and lenalidomide, or azacitidine plus the histone deacetylase inhibitor vorinostat. We learned this from the azacitidine versus azacitidine plus pevonedistat trial. We learned this from azacitidine versus azacitidine plus sabatolimab trial, which is immune therapy, that patients who didn't get enough dose, who had dose delays, who had dose reductions, didn't do as well. So let me give you one example of this. On the North American intergroup trial, when we looked at the median number of weeks that patients received each of these arms, patients got azacitidine alone for a median of 26 weeks, right? So we're talking about 6 months. Patients got azacitidine and lenalidomide for about 25 weeks, pretty close. But they got azacitidine and vorinostat only for 20 weeks. As a result, the response rates were lower for azacitidine and vorinostat, but they were artificially lower,
Yeah,
right? They
yeah,
hadn't gotten enough drug. And when we
right.
actually looked at overall survival, there was a trend towards an improvement in overall survival in patients who got azacitidine and vorinostat. So if they had just stuck with it longer, we may have seen a significant survival advantage to that drug combination.
Yeah,
We used that information and applied it to the azacitidine and pevonedistat trial. Pevonedistat is a NED8 activating enzyme inhibitor. On that study, we had very strict language. You are not allowed to dose reduce. You are not allowed to dose delay. You're not allowed to alter this at all without speaking to a medical monitor. And then the medical monitor was instructed, don't let them alter anything. What we found was something really interesting. If you look at the original studies that led to azacitidine's approval, the CR rate was 17%, and that has been repeated over and over again, a CR rate of 17% for azacitidine. On the pevonedistat trial, the CR rate to azacitidine monotherapy was 32%.
wow, wow.
So it almost doubled
Yeah,
when we were really strict about keeping patients on the right dose and the right
yep, yep.
schedule for the first 4 to 6 months. That's probably my biggest piece of advice to treating anybody, including your 78-year-old patient with excess blasts, to maximize the chance that the drug's going to work.
Got it, got it.
And in terms of transplant, there are a number of trials now, most of them decision analyses or high-tech statistical voodoo that goes into this, that have shown that when we treat patients with higher risk MDS upfront with a bone marrow transplant, we maximize their survival. The opposite is true in lower risk MDS, that we maximize the survival in someone with lower risk MDS if they undergo a transplant after they've already been exposed to a bunch of different types of therapies.
You've mentioned adding a variety of different drugs to the demethylating agents. Where do you see things going in terms of the new clinical trials, and what are some of the things you're excited about?
Yeah, well, so I've dedicated a lot of my career to looking at combination therapies in MDS, and it has been a frustrating career, but I have not given up on it yet.
Okay, good.
So we are waiting for results of a randomized trial that combines azacitidine and venetoclax versus azacitidine monotherapy in patients with higher risk MDS. This combination has already been approved for patients with acute myeloid leukemia. And so you would think, gee, it should work in higher risk MDS, but MDS is trickier to treat than acute myeloid leukemia with a lot more problems with cytopenias. And that's where you have the bone marrow failure aspect to a diagnosis for myelodysplastic syndromes. We are expecting the results to be reported out later in 2025. We've been waiting now for years. If that study is positive, it will be the first combination therapy approved for the treatment of MDS. If that study is negative, I will bet you a nickel there are going to be a lot of caveats to it and subgroup analyses, and someone's still going to try to tease out some positive aspect to it. For now, I am really not giving that combination off label unless I have a younger patient who has a blast percentage that is scarily close to 20%. So they already essentially have acute myeloid leukemia.
Yeah.
Other combinations are being explored. I think one exciting area is thinking about targeted therapy. Ivosidenib, which targets IDH1 mutated MDS, is a very rare subtype of MDS, has been approved by the FDA. People are typically using it after a patient has been exposed to a hypomethylating agent, and that hypomethylating agent has failed that patient. I think increasingly we're going to start to see targeted therapies added to azacitidine for patients with MDS, acknowledging that these are still very rare subtypes of MDS. Already, we're starting to think about the SF3B1 mutated patients, those with ring sideroblasts, as being a potential, quote, target, unquote, for drugs like luspatercept, although both you and I have discussed how we're not really sure that that's targeting a patient in a special way. But I am excited about the future as we finally teased apart a lot of the biology of MDS, what drugs we're going to be able to apply to treating it.
Very nice and very exciting. And I have to say, thinking back again to 30 years ago, what was myelodysplasia and what is it now? I want to reflect back on something you said earlier, which has been meaningful to me in the past half hour. In a sense, the study you mentioned about maintaining dose or dose intensity in MDS is a reminder that it's a cancer.
Yep, yep.
And so, therefore, not calling it what it is really has harm beyond just not being as truthful as we might be.
Completely agree. Completely agree. It is
Yeah.
so important in communicating to our patients the seriousness of a diagnosis of particularly higher risk MDS.
Lastly, just ask you as an author, because you've written about some of your patients with leukemia, but if you were to do a second book or another book, because I know you've written other things, but if you were to do another book on MDS, how might it be different than the first book on leukemia? What stories might you want to share?
So I am actually working on another book, something that's a little broader than MDS, focusing on cancer and identifying what's truth in cancer and what are fallacies in cancer, because I think there's a lot of information that's great out there about cancer. And I think there's
Yeah,
a lot of misinformation as well. And we hear this from our patients. They've, hear things like, gee, I should be avoiding eating anything with sugar in it because sugar feeds cancer, right? That's one of my
right.
favorite ones. So I am working on that. And, I love to include anecdotes about my patients, of course, in a completely HIPAA compliant way,
Of course. Yeah,
because we learn so much from them and it helps us with how we investigate cancers like myelodysplastic syndromes and make other people's lives better. I have some terrific stories from my patients about their occupational exposures, which you never know unless you ask. I think you have to be a naturally curious person and ask how one of your patients has lived his or her life.
yeah,
And that's
yeah.
why when we talk about medicine being a privilege and the insight we get to our patients, it's not just empty words, but we only get to experience that privilege if we make the effort to explore our patients' lives. And I've written about some of these folks have these incredible stories about how their MDS may have arisen. I recall one patient who talked about how he was in the Navy and was sent down in a naval warship during the Cuban Missile Crisis. And he talked about how hot and humid it was as they were, approaching Cuba, of course, because it's in the tropics, and how the only place he could sleep was in the cool, dark hull where he would lie down right next to one of the nuclear missiles.
Wow. 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 Got
So
it.
you can
Got it.
imagine that exposure may have been mutation number one.
Yeah. Yep. Yep. No, I got it. Wow. That is an interesting story. Yeah. I think we're very fortunate to be able to get to know people in this way. And part of the joy of medicine, of being in the healing profession
Yeah.
like that we are.
Yep. Absolutely.
So again, this is Dr. Ken Miller. I have to say this has been such an interesting topic and discussion. What a pleasure to meet and talk with Dr. Mikhail Sikaris, who is the chief in the Division of Hematology and professor of medicine at the University of Miami's Sylvester Comprehensive Cancer Center and the author of When Blood Breaks Down. Mikhail, thanks so much for being with us.
Ken, what a pleasure and a joy it was to be here with you. Thank you for inviting me.
Terrific. Thank you. And I want to thank all of you for listening to this terrific episode. For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, please visit lls.org/CE. And for any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. LLS also provides other resources for patients, survivors, and their families that can be found at lls.org/support. And I encourage you to sign up to receive notification of future podcast episodes by subscribing at www.treatingbloodcancers.org. And if you have suggestions for future podcast episodes, please click the feedback button on this episode page. Finally, we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.